Respected senior members amongst this august gathering, dear friends and colleagues, greetings of the day. At the outset, I would like to put on record my sincere thanks to Professor Ahmed Adam and other members of Urology Summit 2023 who have given me this opportunity. Today, we will be discussing about how to overcome intraoperative problems during PCNL. I bring you greetings from Indraprasth Apollo Hospital, New Delhi, India, where I am working nowadays. Myself, AstraZeneca, and organizers of this conference have no conflict of interest as far as this presentation is concerned. Although PCNL is an easy and routine surgery for most of us, once in a while we find ourselves in difficult situations. The agenda of this talk will be how to prevent and tackle minor difficulties which we may come across during the journey of PCNL. The first step of PCNL is ureteric catheterization, and it is not merely for opacification of pelvic ileal system. Ureteric catheterization also helps us to find out that there is no distal obstruction. So if you pass the cystoscope and if you are not able to even identify the ureteric orifice, what should be done? The causes are either there is a fault to instruments or the light source is defective or the media is having blood, snowstorm or over distension where the ureteric orifices they get stretched out, or there is chronic cystitis, cystitis glandularis or cystitis cystica, malacoplakia or pseudomembrane over trigone, tuberculosis and malignancy of urinary bladder, and sometimes there is a reimplanted ureter or ectopic orifice which you cannot find. So in such situation, when you are not even able to see the ureteric orifice, what should we do? If we over enthusiastically omit this step and make a PCN track, and by chance, if the distal drainage is blocked, if the ureter is obstructed, once we have made a hole in the kidney and there is a distal blockage, this hole is never going to seal. The patient will continue to leak lifelong, and you definitely need another surgery to open up the urinary passage, the ureter. So patient may not be ready for it. This is more relevant these days when we are doing mostly a non-contrast CT scan for all stone cases, and sometimes the contrast studies to opacify the pelvic ileal system and ureter are omitted. So you don't have any information about the ureters preoperatively. And if you make a hole in the kidney at this time, and by chance if the ureter is blocked, then nothing can be done. You will have to do another surgery at a later date. So my request will be, if the ureteric orifice cannot be seen, please don't do PCNL. Abandon the procedure. You should not make a track if the distal drainage is not assured. Or if you have to do, then you should do a antegrade needle puncture, and then from antegrade needle puncture you can inject the contrast and then pass a guide wire. Sometimes it is just merely a chance that you were not able to identify the ureteric orifice, and the guide wire will come in. Then by cystoscopy you can see the guide wire, and over that you can thread the ureteric catheter and do the PCN. For opacification of system, either you can do intravenous contrast, so the picture will be seen as we see in IVU, or you can use ultrasound guidance, and then nephrostogram can be obtained and guide wire can be passed. But my plea is never do making a hole in the kidney unless you are sure that the distal drainage is patent. Second step is, second problem may arise. You have identified the ureteric orifice, you have passed the ureteric catheter, but no guide wire, no contrast can be passed beyond the impacted ureteric calculus. So pelvic ileal system doesn't get opacified. What to do in such cases? How to make a puncture? There will be maybe a mechanical obstruction due to stone. There may be edema because of presence of stone. That is maybe mucosal reaction and hypertrophy. So not even contrast goes in, or the ureter may be in spasm. In such situations, how to opacify the pelvic ileal system? Such situation can arise in this case like the whole stone is impacted and here is another stone in the ureter, in this case where nothing will go in. So how to go about it? In such cases, you should go back and study the preoperative contrast studies and see after intravenous contrast when the pelvic ileal system got opacified. Maybe after 1 hour, because in obstructed kidneys, opacification of pelvic ileal system will take time. So in these cases, it is simply you have to give intravenous contrast and wait for some time. Sometimes when you study, you may be aware even preoperatively that passing the guide wire or passing the contrast through this will be difficult during the surgery. So before shifting the patient to operation theater or giving anesthesia, you can give intravenous contrast that by the time anesthesia is given, patient is turned prone, patient is in position, already 1 hour is elapsed and pelvic ileal system is being seen as in these cases. And then you can puncture. Your ureteric catheter is already here up to this place. Only the contrast was not flowing in. Intravenous contrast has come to opacify the pelvic ileal system. And now you can puncture and go forward. Once your system is opacified, then you can make a puncture in whatever the most convenient calyx, which is being opacified. Inject the contrast from here. Now the PCS gets well opacified and you can do the make a track and do the PCNL. The other method will be if IV contrast, if the kidney is not functioning so well that by IV contrast it will get opacified. So you can do a stone guided puncture. Like if this is the system and it is not getting opacified, you are sure that this stone may be in the inferior calyx. So you can make a stone guided puncture. Once you feel the gritty feeling of the stone and you are sure by 0 degree and 30 degree tilt of C-arm that you are touching the stone, then you can inject the contrast and pelvic ileal system will get opacified and then you can make a track whichever you find better. Or you can use ultrasound for seeing the pelvic ileal system. Or lastly, if the even stones are not there, there is no radio opacity, then you can imagine that this is the area where there is a possibility of middle calyx, which is just at the tip of the 12th rib. So at that level, if you puncture, maybe you will hit the fluid and then you can inject the contrast and opacify the system. So these are the methods of doing blind puncture and opacifying the system. Now, third situation may arise when the contrast has gone in, but there is too much of contrast has gone in and there is contrast extravasation. This can happen. Sometimes the patient comes to us so late that the whole pelvic ileal system is edematous and even guide wire is going out. And if you have not injected contrast, you don't know where is the limit of this. Sometimes you pass the ureteric catheter over here and then when you inject the contrast, it will get extravasated. Sometimes stone is so badly impacted that guide wire finds its path in the submucosal tunnel. And in such cases, when you inject the contrast will go outside and it will get extravasated. The whole anatomy will get disturbed. You will be in trouble. So in these situations, or if your assistant is so enthusiastic and he is going and instilling high volume of contrast in renal pelvis, pharyngeal rupture can take place and the contrast gets extravasated. Once there is extravasation in the beginning, when you are about to start PCNL, it is very disheartening. Now what to do? If the contrast is opacified, extravasated like this, what should be done? And before we discuss that, we should know how we should use the contrast. The contrast should be well diluted. when you are going to put inside the pelvic ileal system. And it should be as much diluted that when you put it beside the stone, filled a syringe filled with the contrast, this contrast should be less than the stone, so that when you inject contrast in the pelvic ileal system, the stone should not get masked. It should be further diluted, and only then much diluted contrast will gently opacify the system and stone should be seen. If such a diluted contrast, even if it gets extravasated, you have a second chance. See, if the contrast, what other things you should do is, you should not allow assistant to go on instilling saline or contrast till free outflow has been established. Use minimum quantity of most diluted contrast in the beginning, comparing contrast with stone density on the same screen. And if extravasation takes place, wait for 10 minutes. Most of it will get absorbed and then try again. Now, next time when you do it, use small quantity of higher concentration of contrast so that you can see the pelvic ileal system nicely, even if there is extravasated contrast outside. And then you can make a puncture and proceed. Otherwise, you can use a ultrasound guided puncture, or because ureteric catheter is already there in the pelvic ileal system, it is only when you are injecting the contrast it is getting extravasated. So now you should very gently try to puncture or touch with the needle directly the tip of the ureteric catheter, which should be in the pelvic ileal system. And then once you can move the tip of the ureteric catheter with your needle, you are sure it is touching, then you inject the contrast and pelvic ileal system will get opacified. Another interesting method is when the ureteric catheter is inside. Now lot of extravasation has taken place. You pass a simple Terumo guide wire through the ureteric catheter. It will go into the pelvic ileal system and then it will get coiled. A nice example I can show you in this case, where there was a secondary PUJ. I passed the ureteroscope up to this place and even contrast was not going in, but somehow I could see a small area where there is a continuation of PUJ, passed the guide wire. Now two guide wires were passed. This Terumo guide wire, when it goes in and if you go on passing, it will go to the periphery of the pelvic ileal system and then get a coil. This is a very usual thing. A Terumo guide wire will coil and try to show where is the distal limit of your calyx. Now, if such thing has happened and there is no contrast inside, in the coil you make a puncture from here in the coil and then inject the contrast and you will be able to opacify the system. So like this, you can coil the Terumo guide wire in the pelvic ileal system and then puncture the coil and then opacify the pelvic ileal system. The last problem which I am going to discuss is inability to pass guide wire. When the stone is bulk is so much, it is filling the whole pelvic ileal system, it is difficult to pass the guide wire. In such cases, when the stones are there all around, all the calyces are full, this situation arises. And in these cases, what you should do is, if you are passing guide wire from here, it is hitting the stone and there is no passage. It is not going in. So you should maintain the needle tip here only and depress the needle hub. When you depress the needle hub and then pass the guide wire, at the same time tell the assistant to inject this saline from ureteric catheter to distend the pelvic ileal system. And now with the this tilted needle, when you will pass the guide wire may slide over the back of the over the posterior aspect of the stone and will go into the pelvic ileal system. This trick has helped me many times. Just depressing the hub of the needle, injecting saline from below, and passing the guide wire again will help you slide the guide wire over the back of the stone. This is a very simple maneuver and gives you success in most of the times. Sometimes guide wire will not go in the pelvic elevation system. It will just go outside and coil in somewhere. You have tried many times, but the guide wire is going every time it is going outside the pelvic elevation system. Now, what to do in such situations? In such situations, you should follow these steps. You should ensure that at least once you were touching the calculus by initial puncture needle, you got the gritty feeling of the stone. There was a strict in touch position of the initial puncture needle in various positions of C arm in 0 degree, 30 degree. You have confirmed that your needle is touching the stone. Some amount of saline also has come out. So it means you have reached to the pelvic elevation system. Now let the guide wire go anywhere and get anchored. You make a track of 10 French only up to the stone. Through this track, you can pass a MIP access from stores. This is a 7.5 French scope or 6 to 8 French ureteroscopes or small nephroscope. If you have, through Elkin cannula, it will go. Then see the stone, identify the stone, identify the use a little irrigation with little pressure. Then you can identify the passage by the side of the stone into the pelvic elevation system. Pass your guide wire, secure your guide wire in the pelvic elevation system, and now you dilate it further and make the track of your choice and proceed. Another point is don't use step or screw dilators in these cases, because if you want to use the step or screw dilators, you cannot make a hole in the stone. You will only injure, you will thrust it inside, and this is the conical tip of this screw dilator or the this step dilators. They will injure and they will cause bleeding. So do not apply force, only dilate up to this, dilate up to the stone. Your maximum dilatation of 30 French will be only up to this place. The Amplatz sheath will come and stay here, and then this much of parenchyma will be inside. So don't use step or screw dilators in these cases. You should use telescopic dilators, either the Elkin telescopic dilators or these are Teflon telescopic dilators which dilate up to the end, and over that you pass the Amplatz sheath, not the conical tip, the straight tip of the Amplatz sheath go in. This is the straight tip which should go in, and it should touch the stone, and the renal parenchyma will get covered from all around. Only then there won't be bleeding and the tamponade will be there, and you will be able to manage the stone very well. Once you have achieved this, and then you see there is a little bit of thin film of tissue in between. Now with the jaws of your forceps, open this area. You can see the stone. You are standing in the renal parenchyma. Now with the help of a lithoclast, break the stone, make some space, take out all these particles. Once this space has been created, gradually and gradually, slowly and slowly, advance your Amplatz sheath inside, and then you will be able to find path into this particular calyx, and then you can proceed further. So these are the tricks when there is a difficulty in making a track and you are able to reach inside the pelvic elevation system. You see all the stone have been in the calyx has been removed, and further progress will be made to remove the stones in the renal pelvis and forward. I thank you for your kind attention and a patient listening. And I would like to take this opportunity to welcome all of you to Percon 2023, which is going to be held on September 30th and October 1st at New Delhi, India. Percon is a dedicated world's largest conference plus operative workshop on PCNL, where we demonstrate 12 PCNLs. There are about 50 faculty members who participate, and usually 700 to 800 delegates attend this conference. This year, Professor John Denstead, Professor Bhaskar Somani, and Dr. Sanjay Khadgi will be our international guests. So you are also welcome. All of us, please make sure that you attend this workshop and the conference. Thank you very much.